let's end this section with, again, post-adjuvant therapy. So do we do anything after, say, TCH or ACTH, a year of trastuzumab? Do we do anything else? And that gets us to Extenet.
So the Extenet trial is an interesting trial, number one, because it's using neratinib, which has been a difficult drug for people to use because of the severe diarrhea that's occurring. And it's interesting now with all these trials that have been done, now we're getting into the trials to figure out how to prevent the diarrhea. And we have the HERA trial, which looked at 1 versus 2 years of trastuzumab with no benefit of the second year of trastuzumab. So it's interesting that they ran this trial.
And the 10-year HERA was actually just presented, right?
Right.
Which shows no benefit even at 10 years.
Exactly,
Right.
just nothing there. So it's interesting that you would now use a different class of drugs, right? You're using a TKI rather than trastuzumab, and so you're following in high-risk patients, either those patients who did not get a pathologic complete response with neoadjuvant therapy, or who are lymph node positive breast cancer, who get standard chemotherapy with trastuzumab, and then randomized to neratinib or no further therapy. And so the overall trial results were fairly unimpressive, but there are now some subgroups.
Like a 2%.
But statistically
DFS.
significant, though. Yeah.
Right, it was statistically significant,
Even
but now
at the
there are
3-year follow-up.
subgroups that are very interesting. One is a third of the patients are not centrally HER2 positive.
Right.
Yeah.
So you've got to get rid of those patients and not even consider them in the statistics. And what was more fascinating to me is that the ER negative HER2 positive patients don't seem to be the patients benefiting from the neratinib. It's the ER positives.
Mm-hmm. But see, that to me that made perfect sense. You know, I thought,
agree.
okay, this is what HERA should really have been powered to look at, which was very difficult. And maybe it's better to change therapies and get a non-cross-resistant treatment. We don't know, but ER, you know, we know already we improve response to hormone therapy by adding in HER2 targeting. So it makes a lot of sense that you're somehow going to change. Now
And
we got
it's
to
really
see the
the
6
late,
year, 8
I mean,
years,
that's what
you
we're
know?
seeing
We
now,
don't
the
know yet.
late,
But
the
they did
triple
look at-
positives
they did,
have that late recurrence.
Right, but they did look at it in HERA.
They
I mean,
did.
they did look at the
They
ER
did.
positives,
They did.
and there's
And there's
nothing.
no benefit.
adding
I have
trastuzumab
a
that
different
second year.
theory. I think it's the crosstalk between EGFR in these and ER in these tumors that is actually pretty important. And when you're hitting the EGFR, and neratinib is a great, you know, it's an irreversible inhibitor, very potent. That may be the difference between HERA and Extenet.
And maybe you get these like luminal B tumors and you get a better effect. I saw there's data on the GBG trial that looked at lapatinib and trastuzumab, and they looked at disease-free survival, and it was superior in the group that got lapatinib in front and then got a year of trastuzumab out back, which was really interesting. I mean, it was a good in the ER positive subgroup. They presented that data at ESMO, and obviously we have to see it published, but it suggests that maybe there is something in that ER positive group that we're going to see.
Yeah, but there was no, did Alto show anything? No,
But
right?
they didn't,
Did they
you know, what's
divide the ER
interesting
positive
about
and
the way
negative
they
also?
did this is that patients who had lapatinib in the neoadjuvant setting had longer duration of trastuzumab exposure after surgery. And that's obviously just inferential based on what we saw in neratinib, but that maybe there is some difference in the ER positive group. And it was just ER positive where they saw that. So I think it's fascinating.
But, you know, the thing that will be challenging if the Extenet leads to approval
Do you
of
think it
neratinib.
will? Do you think it will?
I really hope so. I want the tool.
To be used for other off-label uses?
Well,
I shouldn't be saying that,
I want it
but-
in the adjuvant. I know I want it in the adjuvant setting for the higher risk ER
Right,
positive.
okay, fair enough. I'm
but
just
what if
teasing,
affinity is positive?
Right, then what do we do?
Then what do we do with
Right.
a year
That's a good
of
point.
pertuzumab and trastuzumab together?
Plus, then they're going to have diarrhea for 2 years.
Instead of one, correct? Right.
So I don't know. I mean, there are some studies that are looking at ways to try and prevent diarrhea outside of taking Imodium every day. I mean, if you're taking drugs that prevent diarrhea every day, you know, these people have a lot of bloating and just, they don't feel great.
Right.
So although you do reduce the rate of grade 3/4 diarrhea tremendously, so there's, you know, it seems to be a secretory diarrhea. So one of my colleagues is looking at using a sort of an herbal-like preparation that reduces chloride secretory diarrhea. I mean, it would be fascinating to see if you could really eliminate it with something that was relatively non-toxic.
And we are in San Francisco, so herbal therapy.
Yeah, peppermint oil, you know, whatever.
That
All right.
doesn't work.